Hello, and welcome to the glaucoma lecture series. Today's topic is going to be congenital glaucoma and glaucoma syndromes. Congenital glaucoma in and itself is a very important topic for those of you who are interested in glaucoma, or those of you who practice general ophthalmology, or any in either situation. It's important for you to recognize this entity of congenital glaucoma, uh, as the incidence of blindness is very high if the diagnosis is missed. It's high even when you diagnose it appropriately, but it's going to be devastating to the patient and the family, especially if the diagnosis is missed. And of course, glaucoma syndromes, i.e., systemic syndromes associated with glaucoma, is high on your list of exams. And so I thought I'll put together a talk between the two of them. This is Dr. Ramesh Ayyala from Tulane School of Medicine, New Orleans, Louisiana. And this talk is presented by MediTread, a leader in online training and medical education. Now, this talk would be incomplete um, um, if we don't recognize the person who uh, really explained a lot of things in relation to many of these disorders that we're going to talk today. Otto Barkin, who practiced in Stanford University in San Francisco, he was instrumental in advocating and teaching us two techniques that are extremely relevant and important from the glaucoma point of view. One, gonioscopy, based on which we are able to classify glaucoma into open angle and closed angle, and goniotomy, which is the most common um, surgical technique employed to cure or treat primary congenital glaucoma. Uh, Two techniques that he described in 1950s, 1940s, and 1950s that we still use. Um, and he's a great guy of Hungarian origin, studied in Europe, um, and practiced in Stanford. Had a great career. Um, and we need to salute this man for our understanding of glaucoma, both congenital and narrow angle. So let's start off with congenital glaucoma. Here is a patient of mine who this is day 3 after birth, and this is how she was born. And she was referred to me from the pediatrician's office. And this is typically how congenital glaucoma at birth appear. They have corneal edema, because of which the eye appears to be blue. And of course, the edema is secondary to elevated intraocular pressure. So congenital glaucoma is present at birth. Primary congenital glaucoma, that is. Primary infantile glaucoma can appear in the first few years of life. In both cases, there is an absence of systemic problems, i.e., the glaucoma is strictly related to angle abnormalities. Secondary infantile glaucoma, on the other hand, is associated with inflammatory neoplastic hematomatous, metabolic, or other congenital abnormalities. So we or classifying glaucoma into primary and secondary. Primary congenital glaucoma is related to whether it's at birth, in which case you call it as primary congenital glaucoma, primary infantile glaucoma in the first few years of life. So primary glaucoma, congenital glaucoma incidence is approximately 1 in 10,000. It's much less common than primary adult open angle glaucoma. Um, uh, but approximately 2 to 15% of these patients will end up being blind, unfortunately. So it's a pretty devastating disease process affecting this patient population, and also the entire family gets affected because of this. It's bilateral in about 60 to 80% of the patients, as you can see in this picture. Another patient of mine brought to us at the age of 3 months, even though the mom noticed that the patient's eye were turning blue from the first 1 month after birth. More common in males, 65% versus 35% male-female ratio. In most cases of, remember, primary congenital glaucoma occur in a sporadic manner. Um, and again, I point out, typically a lot of these patients have this blue appearance to the eye simply because of edema, corneal edema related to elevated intraocular pressure. Pretty classic when you see this. Now, there are other ways of classifying this. One of the descriptions that you frequently find in relation to childhood glaucoma is ophthalmos, which is enlarged eye or ox eye. It's related to, again, elevated intraocular pressure before the age of 3 years. The sclera is still elastic before the age of 3, and consequently the globe can enlarge. And as is seen in this particular patient with monocular glaucoma, which was congenital, and this baby was born with unilateral glaucoma in this eye. And you can see that the eyeball is very prominent and has a ophthalmic appearance to it. In relation to diagnosis, 60% are diagnosed by age. Um, uh, Whereas more recently, congenital glaucoma has been recognized as a autosomal recessive disorder in certain families, and is localized to the cytochrome P1B1 gene. This cytochrome P1B1 gene has been recognized in several families with congenital glaucoma throughout the world. In fact, I mean, a lot of research has gone in the last 10 years, and they recognized this gene to be the prime cause um, um, in variety of family settings in different continents and countries. So from the exam point of view, remember, it's a autosomal recessive nature in a small section of the population, a small section of the patients, and it's localized to CYP1B1 gene. Now, in relation to pathophysiology, when Barkin described, Otto Barkin described congenital glaucoma, the feeling was that there is a membrane that's left behind covering the trabecular meshwork, and the idea of goniotomy was to cut this membrane, following which the pathway, aqueous pathway to the Schlemm's canal opens up. And so this theory of a Barkin membrane covering the trabecular meshwork has become popular. Now it is believed that the true Barkin's membrane does not exist, and the primary congenital glaucoma is probably secondary to developmental arrest of anterior chamber tissue derived from neural crust cells. This Barkin's membrane as such has never been identified. Here are some examples, gonio picture examples of congenital glaucoma patients of mine. As you can see, usually they have this lacy appearance to the trabecular meshwork where iris strands are prominently visible in the angle. The iris itself appears to be more anteriorly inserted along with the anterior insertion of the ciliary body. And as I mentioned just before, it represents a developmental arrest in the late embryonic period. So classically, patients with congenital glaucoma, either they're born with glaucoma at birth, in which case you can see because of the elevated intraocular pressure, the blue cornea, secondary to corneal edema that I showed pictures of in the previous slides, or in the first 1 year of life, the mother may notice that the child has the classic triad of epiphora, i.e., tearing, photophobia, intolerance to bright light, and blepharospasm, squinting of the eye. All three of them are secondary to corneal edema. Remember, and this corneal edema is secondary to elevated intraocular pressure. So increased IOP leads to corneal edema. Corneal edema will give rise to increased sensitivity to light, which in turn will give you this triad of epiphora, photophobia, and blepharospasm. Here is a patient of mine, and if you look closely, you can see the tearing, and you can see that the patient is avoiding light. Pretty classic, and sometimes the mother describes that the child would bury his head to avoid the light. So typically, patients with childhood glaucoma have a cornea diameter greater than 12 millimeters of mercury. Remember, normal cornea at birth is between 9.5 to 10.5 millimeters. Remember, 10 millimeters on average is the normal corneal diameter at birth. So anything greater than 12 millimeters in diameter should be viewed suspiciously. Corneal edema, as I mentioned, because of increase in intraocular pressure, will give you that bluish color, discoloration of the eye, and that to the limbus, as is visible in this particular patient here. You can see that the striations, these striations are running horizontally. Now this is in contrast to, so the HAP striae run like this, right? Okay, this is in contrast to decimate tears that happen in a traumatic fashion because of forceps injury, and those are vertical in nature. So the HAP striae from congenital glaucoma, these are horizontal or concentric to the limbus, whereas the traumatic decimate tears or vertical and related to usually forceps delivery. And again, as I mentioned previously, it's secondary to developmental anomaly of the angle structures. Now remember, cornea diameter of greater than 13 millimeters at any age, or between 12 and 12.5 millimeters below the age of 1 year, is highly suggestive of congenital glaucoma. So one of the things that you want to do when you examine these patients is to measure the corneal diameter, both for diagnostic purposes and as you follow these patients, you want, if the glaucoma is poorly controlled, the cornea diameter may keep increasing in the first couple of years. In response to increasing intraocular pressure, remember corneal diameter increases till 3 years of age, after which cornea will not increase in diameter, while the sclera can deform till 10 years of age, and that's the reason why if you do not control the glaucoma in this patient population, they can develop progressive myopia and astigmatism. Now, ophthalmos again is seen in if you have congenital glaucoma that is untreated in the first 3 years of life, right? Whereas as you follow these older kids, you can see one way of checking to see if these patients have continued glaucoma or not, or if the glaucoma is adequately controlled or not, is to refract them. Progressive myopia and astigmatism would might indicate that the intraocular pressure is not adequately controlled. Childhood glaucoma, elevated intraocular pressure is best measured under topical anesthesia. Okay, anything else, the intraocular pressure could be altered Remember, the normal intraocular pressure in premature babies is approximately 10 millimeters of mercury. Between the age of 0 to 1 would be 11, and by the time the child reaches 13 years of age, intraocular pressure, average intraocular pressure normally is 13.9 millimeters of mercury plus or minus 3. Um, uh, so in patients with congenital glaucoma, typically the intraocular pressure is between 30 and 40 millimeters of mercury. Okay, 30 and 40 millimeters of mercury in patients with congenital glaucoma. So how do you measure this intraocular pressure? If you can insert the topical anesthetic drops, and while the baby is feeding or sleeping, quickly use a tonopin and check the intraocular pressure. That probably would be the best way. If you have to do the intraocular pressure measurement under sedation, remember almost all general anesthetic agents and sedatives would lower the intraocular pressure, except for ketamine, which would increase intraocular pressure. This is an important point for you to remember. And so typically when you schedule these babies for examination under general anesthesia, as soon as the baby is slightly sedated, the first thing you want to do is to check the intraocular pressure. So get your tonopin or the Perkins ready for that purpose. Another important feature of childhood glaucoma is the optic nerve cupping. Congenital glaucoma patients, when you examine their optic nerves, they exhibit the symmetric cupping with generalized enlargement, and that's in response to the elevated intraocular pressure. Now, the important thing about this is if you do control the intraocular pressure, immediately this cupping is reversible. Um, and poor control of the intraocular pressure would also present as increasing myopia with astigmatism that as I previously mentioned, and this is because of increasing size of the eye itself, as the sclera does not lose its elasticity till almost the age of 10. So the differential diagnosis for a baby who presents with congenital glaucoma would include nasolacrimal duct obstruction, in which case you can see a mucopurulent discharge apart from the classic triad that we just described, uveitis and corneal injury. All three of these disease processes can present with epiphora, photophobia, and blepharospasm. It's not difficult for you to discern this differential diagnosis, as a close clinical examination should be able to find the actual diagnosis. Now, patients sometimes can present corneal opacities, as is seen in storage disorders and Peter's anomaly and sclerocornea, and that could pose a diagnostic dilemma. And in these patients, obviously, you want to examine under anesthesia and check the intraocular pressure, and if possible, the optic nerve fundus examination to come to a conclusion as to if the patient has glaucoma or not. Megalocornea, again, a congenital abnormality where the cornea is enlarged, is another differential that can present as an enlarged cornea, that can present as a differential for congenital glaucoma. Obviously, in these patients with megalocornea, the intraocular pressure is normal, optic nerve appearance appears to be normal, and the structure of the cornea itself clearly delineates the diagnosis. So as I mentioned, the way we make the conclusive diagnosis in the majority of these patients is to sedate the patient and check the intraocular pressure. Where possible, do gonioscopy and fundus examination of the optic nerve head. And you also, if the cornea is clear enough, you want to do a refraction. So the things that you want to do when you sedate these babies or examine them under anesthesia is A, check the intraocular pressure, B, gonioscopy, 3, C, fundus examination, and document the findings. And then, of course, you want to do a refraction and document that too. Now, remember, as I mentioned previously, most sedatives and general anesthetic agents will lower the intraocular pressure, except for ketamine, which may increase intraocular pressure. So the best way to do this is as soon as the baby is mildly sedated, check the intraocular pressure to get the best readings possible. Normal intraocular pressure under general anesthesia in a baby who does not have glaucoma is between 10 and 20 millimeters of mercury. Um, Now, in about 25 to 30% of the patients, the elevated intraocular pressure is restricted to only one eye, meaning that the glaucoma could be unilateral. Um, how do we treat these patients with childhood glaucoma once you make a diagnosis? You can try medications, myotics, beta blockers, carbonic anhydrase inhibitors, or the mainstay. Remember, myotics generally not effective in controlling intraocular pressure, but are useful prior to goniotomy so as to constrict the pupil and open up the angle structures for better visualization and also to perform the procedure of goniotomy. Acetazolamide or Diamox, 15 milligrams per kg body weight per day, divided over every 6 to 8 hours. Usually well tolerated by these babies. A few side effects include diarrhea and weakness. Um, Timolol is another drug, 0.25% twice a day, one drop, is very effective in up to 70% of the patients, and 5% of the patients can exhibit some side effects, including asthma, bradycardia, etc. So all these medications can have some side effects, but having said that, majority of the patients, the intraocular pressure could be controlled. A combination adrenergic agonists, which have such as brimonidine and apraclonidine, which have CNS effects and using seizures and apnea. So remember, from the medications point of view, the two mainstays are one, oral acetazolamide, and two, topical timolol or a beta blocker. Now, most of the side effects that have been reported with the beta blocker, i.e., timolol, is with 0.5% and not 0.25%. So you would like to prescribe 0.25% in pediatric population. Now, remember, glaucoma is a surgical disease. Congenital glaucoma is a surgical disease, and the treatment, if the cornea is clear, is goniotomy. If the cornea is not clear, as is seen in this particular example, obviously there's no view of the angle structures, and so you cannot do goniotomy, in which case you can do either trabeculotomy, trabeculectomy, or a combination of both. Or if the angle is completely disorganized, then you may want to treat with the glaucoma drainage device implantation. So here is a patient with congenital glaucoma that presented to our clinic. As you can see, the blue sclera, the blue cornea, i.e. the corneal edema in both eyes. There's no angle structures visible. Typically, the way I handle these patients where the visibility to the angle structures is not clear with an opaque cornea, we do an ultrasound examination of these eyes in under anesthesia. These high frequency ultrasound machines are pretty useful to delineate the angle structures. If the angle is appears to be normal, and, on ultrasound examination, I prefer to do either a ab external 360-degree trabeculotomy in combination with trabeculectomy, um, or if the patient's angle is abnormal with multiple iris processes attached to the cornea and the iris, etc., you may want to lower the intraocular pressure by inserting a glaucoma drainage device, such as a pediatric Hammond valve in these patients. Here is an example of a patient where here is a canal. As you can see, and here is the microcatheter that I'm threading through the canal in this particular patient, and within 1 week, you can see how nicely the cornea appears to be clearing up. And this particular patient ended up with pretty decent vision. Um, So again, to stress the importance of this, um, please note that childhood glaucoma is a devastating disease. Um, please understand the concepts of childhood glaucoma so you can make the appropriate diagnosis when you see these patients, and take the time to discuss the findings with the parents. Because the parents have to be on board with you. This is a lifelong treatment that you're going to offer to these patients. Just simply doing the curative treatment at the time is not sufficient. Majority of these patients will develop some degree of amblyopia. You have to work in conjunction with your pediatric ophthalmologist to treat the amblyopia after the intraocular pressure is better controlled. So it's a team effort that is needed. You have to work with the parents, with the pediatric ophthalmologist, and some of these patients with associated systemic diseases that we're going to discuss in the next few slides. You will have to work with the pediatrician and pediatric neurologist as well. In conclusion, congenital glaucoma, when treated, is a very rewarding disease process, in the sense that you are able to restore some degree of vision to this patient population. And some of them grow up to be very intelligent, productive young people. Let's move on to glaucoma syndromes. And this is high yield from your exam's point of view, even though you may not see any or many of them in your lifetime. Um, Mesodermal dysgenesis of cornea and the iris. Um, it's classified into three categories: the posterior embryotoxin, which is a prominent and anteriorly displaced Schwalbe's ring, which is clinically visible; Axenfield's syndrome, which is a combination of posterior embryotoxin plus iris processes to the Schwalbe's ring; and Rieger syndrome, which is a combination of posterior embryotoxin in association with iris processes, Schwalbe's ring, and iris hypoplasia. And even though it's been described as three distinct entities, now it's recognized that this is just a continuum of the same disease process. The milder version of this would be the posterior embryotoxin, and the more severe version would be the Rieger syndrome. Peter's anomaly or Peter syndrome is associated with angle malformation with central iris corneal adhesions and opaque cornea. This is the key for Peters. Peters is associated with iris corneal adhesions and opaque cornea. Here is a patient. The picture that you see has Peters anomaly on the right side, and congenital glaucoma on the left side. So the Axenfeld-Rieger syndrome is an autosomal dominant disorder. Approximately 50% will go on to develop glaucoma. It results from neural crust-derived tissue abnormalities. Here in this picture, you can see the posterior embryotoxin, which is very clearly visible along the limbus. And here is a patient of mine with the Axenfeld-Rieger syndrome, and you can clearly see the polychodia, keratoopia, and iris atrophy in this particular patient that I ended up treating with a tube. To sum up, Axenfeld-Rieger syndrome is autosomal dominant. It's associated with posterior embryotoxin, iris bands to the Schwalbe's line, iris hypoplasia, polychodia, dental anomalies, maxillary hypoplasia, protruding lower lip, flat nose, and wide interorbital distance. Unilateral, most commonly unilateral disorder that is seen in adults between 20 and 40 years of age, can be classified into Chandler syndrome, wherein the corneal endothelial dystrophy is associated with corneal edema and iris atrophy with peripheral synucleal adhesions. or the Cogan-Rees syndrome, or the iris needle syndrome is associated with nodular pigmented iris lesions, iris atrophy, peripheral angiosyncytial adhesions, and ectropia on UVA, as is seen in this picture here. And progressive iris atrophy, which is associated with corneal endothelial dystrophy, iris atrophy, correctopia, PAS, or peripheral angiosyncytial formation, and ectropia on UVA. Um, the primary pathology in all three of these diseases, as I mentioned previously in my previous lectures, is an abnormal corneal endothelium that spreads across the angle onto the surface of the iris. Um, and contraction of this membrane would give rise to the PS formation of peripheral synovial adhesions, closing the angle, giving rise to glaucoma. At the same time, it can choke the iris tissue to either form pedunculated lesions or iris atrophy with correctopia and polychoria, as is seen in this particular patient. So it's the pathology in the eye syndrome patients again is an abnormal corneal. um, Here is the cornea, here is the iris. Um, so there is the corneal endothelium is abnormal, and what it's doing is to spread right across is growing instead of stopping at the Schwalbe's line, it's growing across and spreading onto the iris. And in the process, it's going to pull the iris when it contracts, causing high peripheral synovial adhesions, closing the angle, and increasing the likelihood of developing glaucoma, which is seen in almost greater than 50% of these patients. And contraction of the iris causes the changes that we described. So depending upon which disease is much more prominent, which future is much more prominent, you divide that into these three distinct entities. Um, uh, Okay, let's move on to non-ophthalmos. By definition, non-ophthalmos is in a small eyeball measuring less than 19 millimeters in axial length, with a normal sized lens, because of which you will end up with a very shallow anterior chamber, angle crowding. There you typically have hypermetropia, thick sclera, and may present with uveal effusions post surgery. So got to be very careful in this particular patient. Here is a patient in my own practice with non-ophthalmos. As you can see in the axial length measurements here, our axial length measurements were 18.25 millimeters in the right eye and 18.17 millimeters in the left eye. She was hyperope and measured 45 diopters and required a 45 diopters intraocular lens to correct her hyperopia completely. Um, I treated this lady presented with gradually creeping intraocular, elevated intraocular pressures and angle closure. I treated her with a simple cataract extraction and goniosyncytial, following which the angle opened up, and her intraocular pressures are controlled with topical medications. And she's done well in the last few years that I've been following her. Now, the uveal effusion that has been described in association with this particular syndrome is more likely to happen if you do a cataract extraction using the old-fashioned extracapsular cataract extraction, or if you do a trabeculectomy operation to control the intraocular pressure. You got to be really careful and be worried about the uveal effusion. And so this is one of the two diseases where prophylactic sclerotomy is advised, the other disease being the Sturge-Weber syndrome. So non-ophthalmos and Sturge-Weber syndrome are the two indications for prophylactic sclerotomy to avoid uveal effusions following glaucoma surgery. Fuchs syndrome is associated with heterochromia, cataract, glaucoma. It's unilateral, almost always. Fine angle blood vessels are seen, and this may bleed when you decompress the eye, such as when you enter the anterior chamber for cataract surgery. Let's say you can see bleeding in the opposite angle, and associated with iridocyclitis that is not responsive to steroids. Glaucomatous crisis, typically seen in middle-aged and patients and of unknown etiology. Some people believe this is secondary to HSV. Um, almost always unilateral again, just like Fuchs, but bilateral cases of glaucomatous crisis have been described. Typically, the patient presents with intraocular pressures between 30 and 50 millimeters of mercury, secondary to trabeculitis. The clinical presentation would include mild conjunctival injection, which could be mistaken for a pink eye, mild corneal edema, which would decrease decrease the vision by 2 lines, and examination of the antechamber would reveal 1+ cells, have 1+ flare, and a few KPs, usually in the inferior half of the cornea in the middle. The response to steroids and to glaucoma, topical and oral glaucoma medications. Frequent attacks, however, may result in permanent elevation of the intraocular pressure and may require surgical intervention. Trisomy 13 to 15, all of which may be associated with glaucoma. Infantile glaucoma, they also have a variety of other systemic problems, including microcephaly, heart and kidney defects, and cleft lip, and facial asymmetry, as is seen in this particular patient. Um, Broad thumb syndrome, again, infantile glaucoma, broad thumb and great toe is associated with mental retardation. Hallerman-Streiff syndrome is associated with micro-ophthalmos, cataract, malformed facial bones, and defective hair growth. Pretty classic when you see a patient. The Lowe syndrome is a favorite question that they like to ask in your OCAPs and your boards. The symptoms develop due to lack of enzyme, which is listed here. It's secondary to hyperamino aciduria, leads to mental retardation, cataract formation, microphakia, and infantile glaucoma. Rubella syndrome is associated with infection in the first trimester of pregnancy. It's associated with angle abnormalities leading to congenital glaucoma, congenital cataracts, which is much more common than congenital glaucoma. Both can occur in the same patient. They also may have corneal opacities, microphthalmia, and remember, the cataracts are infected with the virus. And so when you do cataract extraction, make sure that the entire contents of the cataract is taken out. If you leave the cortical material behind, the patient may develop a reporting inflammation because of the viral load escaping into the eye. Here is a patient of mine that I've taken care of. You can see a patient has microphthalmia and had cataract surgeries in both eyes and congenital glaucoma as well. Anardia, another favorite topic from the exam point of view. It's mutation of the PAX6 gene, named for its paired box status on band 13 of short arm chromosome 11. It's familial in nature, autosomal dominant in 2/3 of the cases, sporadic in nature in 20% of the cases. Among the sporadic cases, 20% are associated with WT1 region adjacent to the AN2 area region causing Wilms tumor. So 20% of the sporadic cases may be associated with Wilms tumor. That's the take-home message here, a very important take-home message. So you need to screen these patients, and 2/3 of these patients are of autosomal dominant inheritance pattern related to the PAX gene defect. Now, there are a couple of syndromes associated with aniridia that they like to test you on. Gillespie syndrome, which is seen in 2% of the cases. It's autosomal recessive disorder and associated with cerebellar ataxia, mental retardation, and aniridia. The WAGR syndrome, which is autosomal dominant disorder, seen in 30% of the cases. The WAGR stands for Wilms tumor, aniridia, genitourinary anomalies, and mental retardation. So, in conclusion, aniridia is associated with Wilms tumor in 20% of the cases in the sporadic group. As far as the eye is concerned, these patients from anterior segment to the posterior segment, they have lack of limbal stem cells, because of which they can present to you with pannus as the patient ages. So by the time the patient is like 20 to 30 years of age, you can develop diffuse corneal opacities because of this pannus formation. Two, they can have angle abnormalities leading to glaucoma. And usually this is seen in between 10 and 20 years of age in teens because of retraction of the iris stump towards the angle trabecular meshwork, closing the trabecular meshwork, causing glaucoma. Three, they can develop cataracts. And these patients have macular hypoplasia, because of which they're associated with pendular nystagmus. And as you can see here, there's no macular reflex that is clearly visible. And so aniridia patients, to summarize, have lack of limbal stem cells, leading to cornea pannus. Two, angle abnormalities that can present to you as delayed glaucoma. Three, cataract formation that may need cataract surgery. Four, macular hypoplasia, secondary to which they will develop pendular nystagmus and amblyopia. So, like I mentioned before, the glaucoma in aniridia is secondary to angle closure from iris stump retraction and blockage of the trabecular meshwork. It's typically seen in the first and second decade of life. Prophylactic goniotomy, if you observe these patients in a serial fashion and you notice that the retraction of the iris stumps is taking place, David Walton from Boston, one of my mentors, suggested that prophylactic goniotomy at that stage might prevent these patients from developing glaucoma. If they do develop glaucoma in spite of your efforts, or the patient already has glaucoma by the time you see the patient, then a glaucoma drainage device implantation is the treatment. Weil-Marchesani syndrome is an autosomal dominant disorder associated with this ADAMTS10 gene mutation. Autosomal recessive, some patients are autosomal recessive, and they are associated with this FB1N1 gene mutation. They're associated clinically with microspherophakia, which is how the patient typically is seen in the eye clinic. Brachydactyly, short stature, myopia, inferiorly displaced lenses, as opposed to Marfan's, where you see that the lens is superiorly displaced, and pupillary block leading to glaucoma, secondary to microspherophakia. So they have a small round lens that can cause pupillary block glaucoma. The lens can get displaced inferiorly. They're associated with increasing myopia and infantile glaucoma. So from the point of view of exams, and also if you ever were to be involved in the care of these patients, remember, airway management during anesthesia can be difficult because of stiff joints, poorly aligned teeth, and maxillary hypoplasia. Ophthalmic myotics and mydriatics should be avoided because they can induce pupillary block in an eye with microspherophakia. The treatment obviously is extraction and trabeculectomy. The lens extraction in this patient population is kind of tricky, and if you don't have the experience to deal with this kind of lenses, it's best to refer the patient to someone with experience to deal with this particular kind of cataracts. Marfan syndrome, another favorite, and one of our most famous presidents had Marfan's syndrome. Um, Abraham Lincoln. It's an autosomal dominant disorder. It's carried by FBN1 gene that encodes fibrillin 1, which is a connective tissue protein. Now, fibrillin normally binds to TGF beta. Abnormal fibrillin leads to excess TGF beta, which in turn leads to damage to the lung, heart valves, and aorta, leading to this disorder that we call as Marfan syndrome. Now, it affects a wide variety of systemic systems in the body, including the eyes, lungs, where it can cause pneumothorax. In the cardiovascular system, it can cause aortic dilation, aneurysms, mitral valve prolapse. Skeletal system is affected too, including scoliosis, pectus deformities, tall stature, loose joints, etc. Here is an example of how these patients look. From the eye point of view, these patients have ectopia lentis. 80% of in 80% of the patients, usually the lens is displaced up and out, as opposed to Weil-Marchesani, which is down and in. They are associated with high myopia, increased risk of retinal detachment, open angle glaucoma, and skeletal abnormalities, as we discussed previously. Let's move on to phakomatosis, which or spot glaucoma. This is another hot topic that they frequently ask in your OCAPs or boards. These are neurocutaneous syndromes. They affected tissues are of common ectodermal origin. And typically, it affects the fibromatosis. Now, so the Strach-Weber syndrome or the encephalotrigeminal angiomatosis is associated with unilateral port vein stains of the face, glaucoma, seizures, mental retardation, and ipsilateral leptomeningeal angioma. So typically they have a cavernous angioma of the face, as is seen here. They have angioma of the choroid in the eye, and they have leptomeningeal angioma all on the same side. It's caused by an AV malformation that occurs in the cerebrum of the brain on the same side as the physical signs described above. Normally, only one side of the head is affected. It is an embryonal developmental anomaly resulting from errors in mesodermal and ectodermal development, okay? Unlike other neurocutaneous disorders, Strach-Weber syndrome does not have a hereditary tendency, but occurs in a sporadic fashion. Remember this. They do ask you this. Strach-Weber does not have any hereditary tendency. So from the clinical point of view, these patients present with seizures that begin in infancy. They exhibit developmental delays, mental retardation. In 50% of the patients, they have glaucoma, which can present at birth or develop later. If it presents at birth, these patients can develop ophthalmos. Here is an example of how the eye looks. As you can see, there's a port vein stain of the lid. You can see dilated conjunctival blood vessels, and you can see cherry red appearance of the retina because of the choroidal angioma. Treatment in Sturge-Weber's syndrome-related glaucoma. You want to try glaucoma medications initially. If that doesn't control it, you may want to go for surgery, but with extreme caution. Avoid surgery to the extent possible. Again, like I mentioned before, non-ophthalmos and Sturge-Weber syndrome are both afflicted with the uveal effusion syndromes, uveal effusion soon after glaucoma surgery. And so, as a prophylaxis, you may want to perform scleral windows or sclerotomies, or recommended to prevent these uveal effusions. Or the pathology behind this is pretty interesting. In non-ophthalmos, it's a thick sclera that prevents the uveal fluid from escaping transscleral fashion. Whereas in Sturge-Weber, I'm assuming that it's the leaky blood vessels that leak out so much of this fluid into the suprachoroidal space that the system is overwhelmed, and you will end up with massive uveal effusions. Neurofibromatosis is a autosomal dominant disorder. It's the most common of all the phacomatoses. This disorder affects all neural cross cells, including the Schwann cells, the melanocytes, endoneural fibroblasts, and consequently, you can have a wide variety of CNS tumors seen in this disorder. The neurofibromatosis is of two kinds, type 1 and type 2. The type 1 is the peripheral neurofibromatosis or von Reckling-Hansen disease. This is the most common variety, seen in 1 in 3,000 to 5,000 patient population. It's autosomal dominant or sporadic in nature. The defect is in band 11 of the long arm of chromosome 17. So what are the ocular findings in neurofibromatosis type 1, ectropia and UVA? If you see an infant with ectropia and UVA, you need to screen this baby for neurofibromatosis. Leash nodules, optic nerve glioma, eyelid neurofibroma, and glaucoma, especially if the patient has upper eyelid neurofibroma. You need to, a lot of those patients with that upper eyelid neurofibroma do develop glaucoma, so you need to screen them or watch them for that. Now, sometimes the neurofibromatosis type 1 is combined with Proteus syndrome. Elephant man is an outstanding example of this combination. For those of you who don't know about Elephant Man, he was born in London and during the Victorian era, and because his diagnosis was he was not diagnosed in those days properly, he was treated like a circus animal, unfortunately, and exhibited in the London circus. These patients have overgrowth of skin, bone, muscle, fat, blood vessels, and lymphatics. This is a picture from Wikipedia of this elephant man, and you can see the deformities of the skeleton. Future that is associated with this bilateral acoustic neuromas. In fact, the hallmark of neurofibromatosis type 2 is hearing loss due to acoustic neuromas around the age of 20, associated with multiple other nervous system tumors. As far as the eye is concerned, these patients do not exhibit glaucoma. The only ocular finding that type 2 has is PSC cataract, or posterior subcapsular cataract formation. There are a host of other pediatric glaucomas, conditions that are associated with intraocular tumors or retinopathy of prematurity. The ROP glaucoma is because of angle closure glaucoma. Just to complete the discussion here, I would encourage you to read Chandler Grant's new version of the new edition textbook if you want to gather more information on these pediatric glaucoma syndromes. So the treatment for infantile glaucoma, just like adult glaucoma, will include medications, lasers, and surgery depending upon the condition. In majority of these patients, you want to try medications. If it's not effective or poorly controlled, then you want to go for surgical intervention. But every time you do surgery in infantile glaucoma patients, you got to be really careful. I will leave you with a reference paper from my mentor, David Walton from Boston. A great review that's published in 2005 in the Journal of Pediatric Ophthalmology and Strabismus. Newborn primary congenital glaucoma gives you a great summary of the disease process. As always, thank you for listening to this lecture, and please look out for more lectures on MediTread YouTube website, and look out for our CME, upcoming CME and board review courses. If you have any questions or comments, please contact me at ayyala@meditread.com or